Practice managers and billing teams often treat HEDIS abstraction as a quiet, back-end task. But when data is missed or coded incorrectly, it quickly becomes the most expensive problem in the building. To understand why, we have to look at the scale of the system. According to the NCQA, over 235 million Americans are enrolled in health plans that report HEDIS results. That is nearly the entire insured population. This chart shows how clinical data translates into revenue. HEDIS scores feed directly into CMS star ratings. Achieving 4 stars qualifies a plan for quality bonus payments. But if abstraction is sloppy, practices lose credit for the care delivered. When data is incomplete, star ratings fall and bonus payments disappear. The most visible symptom of this breakdown is a spike in claim denials. According to Kodiak Solutions, hospitals and healthcare organizations lost more than $48 billion to claim denials in 2025. That is a 25% increase over the previous year.
Industry data from Billing Paradise suggests that coding errors contribute to nearly 40% of all denied claims. And because the average cost to rework a single denial is over $118, a practice generating 500 denials a month is spending $700,000 a year just on administrative rework. These errors aren't just paperwork issues. They are an active hemorrhage of earned revenue, bleeding practices dry one denied claim at a time. HEDIS abstraction is difficult because it requires coders to go beyond simple billing. They must dig into the EMR to find specific clinical evidence, like A1C levels or blood pressure readings. These metrics aren't always found in claims data. They require clinical judgment and native access to the chart. The specifications also change every year. For 2025, the NCQA added new requirements for social determinants of health and digital data tracking. For a generalist coder, these evolving benchmarks are easy to miss. At the same time, the risk of being caught is rising. In 2026, CMS increased its auditing activity to review all 550 eligible Medicare Advantage plans annually. That is a sharp jump from the 60 plans previously audited. Trying to solve this in-house is often a financial trap. A qualified HEDIS abstractor typically costs a practice between $55,000 and $75,000 per year when you include benefits and training. With industry turnover rates often exceeding 30%, that is an investment you have to make over and over again. This leads to the seasonal crush, where practices try to rush through chart reviews as the measurement year deadline approaches. As the workload spikes, accuracy usually drops. Treating HEDIS as a seasonal chore for generalist staff is a structural flaw that makes errors almost inevitable. High-performing organizations utilize a completely different blueprint. They shift away from seasonal sprints in favor of rolling chart reviews, identifying care gaps throughout the year while there is still time to close them. They also rely on credentialed specialists. Coders with specific HEDIS training from AHIMA or the AAPC consistently outperform generalist billing staff. Native EMR access is the next requirement. Abstractors working directly inside the chart catch physician notes or specialist consultations that a flat batch report would miss. Finally, they maintain a rigid quality control layer. By performing independent audits and daily supervisor reviews of random samples, these organizations keep their error rates below 1%. Achieving this level of accuracy requires a specialized operational blueprint that most mid-sized practices cannot afford to build internally. This is why many practices are moving away from in-house hiring. Instead, they are outsourcing the entire workflow to credentialed, EMR-native teams. Staffingly provides AAPC and AHIMA-credentialed specialists who operate as a dedicated extension of your practice. They work inside your existing EMR every day. The economics are direct. An in-house seat can cost up to $75,000 fully loaded. Staffingly delivers the same expertise for $399 per week, or roughly $20,000 a year. Implementation is handled through a 14-day go-live sequence. The infrastructure is fully HIPAA compliant, backed by SOC 2 Type 2 and ISO 27001 security standards. By the end of those 2 weeks, a practice has an enterprise-grade operational blueprint in place, with the costs of training, benefits, and staff turnover eliminated. To maintain high throughput, Staffingly uses AI-powered tools for smart routing and workload management. This ensures that complex charts are prioritized, and no single abstractor is overburdened. The AI is a productivity aid,
not a replacement for judgment. Every abstracted chart is verified by a trained human eye, keeping error rates below 1%. Combining human clinical judgment with an AI-assisted workflow is a highly sustainable way to stop HEDIS revenue leakage. It is time to stop spending senior staff hours on manual chart pulls. Start a 14-day risk-free pilot and see how much revenue you can reclaim.